I am.
Okay, thank you.
Tell me when we're live, because I can't see it on the screen.
It shows it's still loading on my end, but sometimes people have told me that it's live before I can even see it. Okay, it should be now.
It's live now. Okay. Good afternoon and welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operations Committee. We're grateful that you're here. Today's meeting is of the subcommittee members to do a look at the latest reprint of HB 565, which is Health Facilities, Hospitals, Medical Debt Protection. Before we get started, I wanted to just say thank you very much to the committee who has spent a great deal of time on this bill, and also the fact that I know that advocates have been reaching out to you frequently. And so I appreciate your patience and listening and your indulgence and trying to put everything into context. I also appreciate and thank the advocates for their commitment to consumers on this very, very important issue. And I thank the Maryland Hospital Association for their diligence in helping us to understand the potential impact of the policy and each element of it. I think I would characterize the goal of this bill as putting up reasonable guardrails in how medical debt is both identified and collected in Maryland that protects the most vulnerable people and responds to the fact that we've just experienced through this pandemic that people's financial situations change, and therefore their ability to pay their debt may change as the result of that. So we wanted the bill to be responsive to that as well. And we'll be using, and I think this is an important part of the bill to understand, we're going to be using this bill to gather information about medical debt as it applies here in Maryland hospitals, now over the next year or so that we can use that information in policy making going forward. Those of us who have served in the legislature for a while, we understand that sometimes a bill is a starting point, and we need to know more before we can go further. And I kind of view the bill in that way. The reprint that you have on the screen in front of you is the most recent reprint. I think it was done at 11:35 today. It is the result of numerous discussions and interactions with all of the advocates, and committee members. You participated in 3 hours of those discussions yourselves in our subcommittee meetings last week. So we tried to listen to what folks said and took a measured and reasoned approach to addressing the issues as they arose and as they were identified. So the process that I'd like to use today is we're going to go through the bill page by page. I'm just going to ask you to identify a concern that you have, not discuss it. Just say, I have a problem with lines, 5 and 10, or I have a problem with lines 20 and 43 or whatever. And so just identify the issues that you have. And then I'm hoping that we can move all the amendments that we don't pull out as having an issue, and then we can go back and discuss the ones that have issue. So I hope that process is, if it's not clear, that it will become clear as we go along. So, and I will apologize in advance that my dogs are likely to bark during this meeting. There are no changes on pages 1 and 2. We're going to start on page 3, and the lines 1 through 5 are lines that we've seen before. 6 through 11 are lines that we've seen before. What is new F makes an attempt to increase that notification to patients about charges and also about the financial, the ability to request financial assistance or to be eligible for free or reduced cost service. So
Delegate Cullison,
oh, I'm sorry. Yes.
is this the one that was sent at 11:35 a.m.? Does it say that?
Oh, no, it doesn't. Sorry. I've got to go back. I thought I had pulled that right one up. I apologize to you all. Let's see. It's in a Word document, right?
Thank you. It's hard enough to follow, but if I'm not following, it's from
You're not following the right one.
11:35 from today. It's 3:50,
Yep,
11:35.
It's okay. They both are. Nope, that's still this. It looks like they have the same name. That's my problem. I'll try this one. It's still coming up that.
I just forwarded you the most recent one Aaron sent, emailed.
Okay.
That should
All
be
right.
it. Check the timestamp.
Let me open up.
Okay.
Oh, here it is. Nope. This is 11:35. Here we go. All right, let's try this again. Sorry. Okay, here it is, 11:35. Thank you, Aaron. Sorry for that. Okay, so we're going now to page 3, and now we can see where it explicitly says in F, include a section that allows the patient to initial that the patient has been made aware of the financial assistance policy. That section is in response to the request for oral notification and acknowledgement of oral notification. So this would happen when the patient, this part would happen when the patient is generally being discharged from a hospital. The report that's being asked for is essentially the same, except that in lines 26, we have added, because we're trying to gather data on what the who's most affected by medical debt. And in fact, what we're learning is that there are people with insurance who are affected by it because of the high deductible plans. And so we're trying to capture that in this study. So are there any parts of this page that you have a problem with? Just again, identifying the problem. Let me pull up my participants. Okay, I see no hands. We'll go to the next page. The next page has...
Madam Chair, I'm sorry. I'm having trouble. My hand wouldn't go up because I got this screen.
Okay.
I just had a question about what you just said about the out-of-pocket costs. Is that going to like break it down to this? I appreciate that. The copays and the high deductibles, so we will know, was it because they had a high deductible plan or they had high copays? Is that what that means?
Yes, that's what we're trying to get at.
Okay. And then on this report by the commission, I had a note to myself about the impact of these high deductible plans on not only medical debt, but also on the HSCRC on the rate setting. Because I had asked the question in the last subcommittee meeting to the HSCRC person, and they did give me a response. My question was, would the reporting requirements in this bill allow us to understand the impact of this bill on total cost of care? And they wrote back and said that they did not think it would be adequate to allow the HSCRC to model the impact of this bill on uncompensated care and total cost of care. And I want to make sure somewhere in this bill, and I don't know if it's here or somewhere else, that the HSCRC is going to have enough information to determine that. And
Well, they'll have actual, because of the way they're required to gather it here, they'll have actual information on what's happened. They won't have to model. They're going to see. So
I'm just asking, based on the conversation we had at the last subcommittee hearing, they said they didn't think so. Maybe this takes care of it, but I don't know if you've talked to them to make sure.
Well, we didn't have this out-of-pocket cost in the last version. It
Okay.
was just insurance, yes insurance, no insurance. So we've added this piece.
Okay, and it would be the impact on the debt collection and also the impact on the total cost of care.
Total cost of care, and some of that will be in the later report as well.
Okay. I just didn't know if this was the appropriate place or not. Thank you.
Well, we're gathering the information here, but we're going to use the information later. I think page 4 is essentially the same as what we saw last time. Is there anyone that wants to pull out any lines on page 4? Okay. Not seeing any hands. I will move to page 5, which we do have some changes in. Several folks raised the concern that lines 16 to 26 were not adequately covered under the development of a income-based payment plan. So we put lines 20 to 22 back in for this section. And it applies to free and reduced cost care in that section. Any places that folks want to pull out on page 5? Delegate Carr.
Yeah, thank you, Madam Chair. Just wanted to flag again the geographical issue, by not adding back in reduced cost care that has a disparate impact on high cost areas, like Montgomery County, Prince George's County, other parts of the state. Thank you.
And I hope that will be covered for you in the next section when they're developing the payment plan. Okay, we're going to the next page. Most of this is the same because what we have done in my discussions over the weekend with representatives of the HSCRC, they preferred not to be the body that would develop the payment plan. And the original bill did not call for a third party to do that. Since we've worked on this bill, we've developed a lot more guardrails in what that payment plan would look like. So what we are proposing here is that each hospital, in consultation with the hospital's patient advisory committee, because we also had a wish that stakeholders would be involved in the development of the plan. And each hospital has a patient advisory committee that's comprised completely of consumers. And that committee would be involved in the development of the income-based payment plan that Delegate Carr, I think that's where we're trying to address the issue of geographic equity. And it would have to include all of these things. I think all of them you've seen before. It prohibits interest payments on, it maintains the prohibition on interest payments for free and reduced care. Then it also says, in terms of looking at interest that's not on a payment plan, and someone who does not qualify for reduced care, that they would be considering, an allowable effective rate of interest and a determination of when interest may occur. And then on or before this year, November 1, each hospital will submit and obtain an approval from the commission of the payment plan, the guidelines for hospital charges on interest. Okay, so that's what's happening now with the payment plan. And another issue that was raised in our discussions was the hardship that debt collection is happening to people right now, when we are perhaps in one of the most economically depressed times that we've had. So in order to mitigate that, we have said that a hospital may not collect on a debt until the hospital has established and implemented the payment plan that was developed under this. So effectively, it stops collection by the hospitals from now until, at the very earliest, November 1st. Probably November 2nd, because they'd have to get approval from HSCRC. So,
I got a question on that.
okay,
I'm not sure.
Perhaps why?
pardon, Della Krebs?
Oh, no, it's not why, but I mean, so each hospital is going to have their own advisory committee. So they're going to have, every hospital is going to have a different way they do it.
They already have an advisory committee that already exists.
Yeah.
And so yes, with these guardrails in place, each hospital will have to determine, how they're going to approach the income-based, but it will have to be approved by the HSCRC. They can't implement it without the approval. So there is some, oversight in the development of the plan.
But you would think, you'd want some consistency, even within one system. Each hospital could have different payment plans within the University of Maryland Medical System, or within, Hopkins, or within LifeBridge. Every hospital could be different.
I think that's absolutely true, except it's got to meet those guardrails, number one. And what the hospitals were originally asking for was the flexibility to respond to environmental issues and aspects that you might want to consider. And again, I go back to, if you're located in Baltimore and you're serving a population that may be over that financial eligibility cliff, then you're going to take into consideration the cost of living there, the cost, what financial hardship looks like in Baltimore, as opposed to what financial hardship looks like in Montgomery County. So they would be responding to their environmental elements in this plan. Delegate Lewis Young.
Thank you, Madam Chair. I do share a similar concern with Delegate Krebs about the lack of consistency. My only objection to the commission handling this payment plan was that there wasn't a provision to allow stakeholder advocates on that commission. And I have a similar concern with these advisory committees. How do we ensure that there are people on these advisory committees that represent the community?
I'm going to look to Aaron. Aaron, can you talk to us? Do you know about who sits on those advisory committees?
I do not. I know that all the hospitals have them, but I was trying to do a quick find out while we were sitting here. But I can look into it, and maybe by the end of the Zoom, I could have an answer to you.
Okay, yeah, if you can, see what you can find out. My understanding is that these are folks from the community that they serve.
Well, that could be, but how you select people from the community, are you representing all interests and income categories?
Again, I'm not sure how they're designated, so we'll see what we can find out. Delegate Bandari.
Yeah, thank you. I want to echo Delegate question as well. And just my thought is when different hospital, they develop the different advisory committee, there might not be an uniform and there it could be a patchwork of approaches which will confuse consumer, and it might make more difficult for a patient to understand their rights. Sometimes there is already the issues of the communication. I would also agree to put the labor union leaders and other folks, stakeholders, so in that way we could understand what's going on in a very comprehensive way. Then the one particular hospital, they might not have resources and stuff like that. So I would like to echo Delegate Krebs. I'm sorry, Delegate Lewis on this.
Okay, then we will make sure that we pull out for later discussion the section 3, beginning on page 6 and going through line 23 on page 7. Okay. So that's the payment plan.
Madam Chairman, are we on page 7 now, or?
Yes, we just got to page 7, and I'm going down to line 23 on page 7.
Okay, I have some questions on that when you get a chance. Or
Okay, so we're going to hold lines 23. Okay.
sorry, I'm using my phone trying to do everything, Zoom and look at the notes.
So which part do you have a question about, so we know what we're coming back to?
I'm trying to, hold on, I'm sorry. At the beginning of line 7, I'm sorry, page 7.
Okay.
It's where it says files action to collect a debt owed on the hospital, on a hospital bill by a patient, or delegates collection activity to a debt collector. Are we?
I don't think that's not the page we're on.
Okay, I'm looking at the reprint. It say page 7 of 13.
Okay.
It's
Yeah,
line.
but we're not there yet.
I think this is an extra
Oh.
page that's been
Yeah,
submitted.
right. This is an extra page. Right. Okay. Thank you.
Okay, that's why I
Thank
was
you,
asking
Delegate.
if page 7.
Yeah.
Okay,
Okay.
I'll wait.
We'll get there.
Okay.
Okay. So lines 23 through 27 are the same as we had before. We put back in 1. So we said that, let me see if I can stretch this out a bit. Okay. The last time we met, we had taken out line 28 and 29 and 1 and 2 on page 7. What we're saying is the hospital cannot begin collection until they have filed an action to collect or they've delegated collection activity to a debt collector. However, the reason we had deleted that in the past was because the hospitals were saying that they use the debt collection agency to do financial eligibility measurements. And what we've done here is to say they can't collect debt until they have done those 2 things. They can use a third-party eligibility vendor to for the purposes of assisting the patient in qualifying for financial assistance. So we're trying to say, no, you cannot do debt. You can use a third party, but it's not debt. It's how do you assist in qualifying for financial assistance. Does that answer your
Right.
question, Delegate Saab?
Well, yeah. I mean, I guess I prefer to strike, but go back to striking line 1 and 2, because sometimes the inability to collect balances because it's problematic. Because what if the patient doesn't respond to financial assistance for reduced care, or if there's no way of knowing that this person qualifies, so why tie their hands by putting it in there?
Well, no, what we haven't
By
tied their
removing
hands.
it.
We're just saying they have to file the action. Right, so, or they, they have to file an action.
Right. So are we striking line 1 and 2?
Oh, I see what you're saying. No, we've left it in, that we're saying they cannot do that until they have, oh, I see what you're asking. I'm sorry. I'm a little slow in the uptake right now.
That's fine. That's what I'm saying. So how would they
Yeah.
know? That's what I'm saying. We should strike them, because this way the hospitals don't always have a way of knowing that this person is actually qualifies for financial assistance or reduced cost care. So why not strike it? And because we're tying their hands by doing
Okay.
that. It just makes it
We'll-
more difficult for them.
We'll come back and talk about that.
Okay.
Okay, because I want to move through the bill to see where the issues are. Okay. The rest of this page, we go down to page 20.
Madam Chair, good. I'm not finished on 7. There's
Oh, I'm sorry. Sorry.
You skipped
Yeah.
from 7 to 20. No, on page 7, lines 18 and 19.
18 and 19. Okay.
Okay, what changed on that from the last? A hospital may not report adverse information about a patient to a consumer reporting agency, commence a civil action against a patient, or delegate collection activity to a debt collector.
So
Okay,
nothing,
so you-
nothing changed there.
So it seems like, so you're saying that in line 2, where it says nothing in the subparagraph prohibits a hospital from using an eligible vendor to provide outreach, you're saying that trumps whatever you want. I got to define a new word. Trumps line 16 to 19. That is the intention. Because when you read line 16 to 19 or 18 and 19 on their own, it basically says you can't delegate collection to a debt collector. So, but you're saying except for the things that are allowed up in.
No. You need to, this number 4 is constrained by Roman numeral 1. Because if the hospital was informed, and we went back and forth on the information, what that looks like.
Mm-hmm.
And what Pat O'Connor said to us is that the federal law requires certain kinds of notification. So what we've said is, if the hospital was informed in accordance with federal law by the patient or the insurance carrier, so they can't report adverse action if they have been notified, is basically what that's saying. Does that make sense?
Yeah, but it seems the way it reads to me. Well, I mean, we can come back to it, but I want to make sure what we think it does is what the words say. Because
Okay.
the intention, it seems like the intention, what you're saying sounds right, but what the words say, because how do you collect on outstanding debt until after a payment plan has actually been established? I mean, you got to establish the payment plan with the debt collector before you can even try to collect.
Right, but what we're saying is that under federal law now, and state law as well, they can't try to collect if they know an appeal is in process.
So what about the situation where a person, I mean, one of the most common things I think with hospitals is that patients fail to respond, or they fail to connect. So how do they move forward if the patient does not respond to financial assistance for reduced care costs? How do they even know that they need to set up a payment plan?
Well,
If they can't make the connection, I mean,
Right. Well, I mean, that's what we're trying to get at this bill with all of the different kinds of notification that they're required to make. And if the patient isn't responding, at some point, the hospital has to move into debt collection. So we're trying to put the parameters around when they can do that in a reasonable way.
and where is that later in the bill? Like what that period of time is?
Well, there's time, there's up to 240 days total that this can happen. If they haven't heard back from the person in 240 days, then they can go into debt collection.
Okay. And I keep, my overall, I keep saying this. I know it's nice to relieve people of debts if they're not responsible to get back to you. What does that do to the ability to collect on debt? How will that have a negative impact on uncompensated care, which affects everybody and it affects our total cost of care?
Right.
So that's my concern.
Right. No, I understand. Okay. So is there anything else on this page, on page 7?
Hey, Delegate Collison, it's Delegate Charles.
Delegate Charles? Yeah. Delegate Charles? You're on mute.
Okay, how about
There we
now?
go.
Good now?
You're good now.
All right, so when the hospitals are sending out letters in those 240 days or making the phone calls to reach out to the folks who owe, laying that out in the letters or even in the phone call to let them know exactly how much they could owe. So for instance, if the folks just don't know how this process works, so when they get a letter in the mail and it says, you owe $150 on this for this bill at the hospital. If you can't afford it, we can get you a monthly payment plan as low as $2 a month for you to be able to make the payments. If you do not agree to this $2 a month by this particular date, we will then send you to collections. Is there something laying that out verbally and in writing so people know? Because I think if they understood that in writing or verbally, they'll be more willing to move forward. And I say verbally also because we got some people who just can't read realistically within our communities. And so trying to make sure folks have every option available to understand how low those payments can go. And I know it's kind of double-edged question because I know another part is we have the hospitals making up the guidelines as to how low those payments will go. Based on
So I can try to answer the first question. With each notification that the hospital sends out with a bill, they currently include a number to call, information about the appeals process, and how to get financial assistance. So, there is some burden on the patient to initiate the call if they need to apply for financial assistance. But they receive a monthly statement for, at least the first 6 months that gives them all, these resources that are available to them. So we need, them to follow up on this whenever they can, and in the end, if there's a collection placed on them, then they would have another opportunity to appeal. And we can be very clear that they can appeal to the Office of the Attorney General and to the Office of, and to the Maryland Insurance Administration. So I think that we're trying to be reasonable in the expectations on both parties.
So, Madam Chairman, are we going back to page 7?
Right, we're gonna go back,
Okay.
right, to things that are unresolved. I'm just trying to get an idea of how much is unresolved.
Okay.
All right, so on page 8, we have, it's almost all the same, except that in lines 23 and 24, we've said that they cannot make a claim against the estate of a deceased patient at all.
Well, Madam Chairman, can I say something on this?
Do you want to have a discussion on it? Let me pull it out for
Yeah.
later discussion. Okay, so
Yes.
page 8, and it's 23, 24. Okay. All right. Anything else that anyone wants to pull out on this page? Delegate Lewis Young.
Thank you, Madam Chair. I would like to further discuss or pull out the line that we have consistently discussed all along, and that's that a hospital may not file an action against a patient to collect a debt owed on a hospital bill in amount of $1,000 or less. And I'm going to recommend a compromise that we make that $500. I think that's a reasonable compromise. And according to my own experience and the data I've seen, $1,000 at best, the hospital is collecting 50% because their collection and legal costs.
Delegate, can I ask you to hold the debate till we find out, because remember, we're going through just to pull out areas where we have concerns. So I've noted that on page 8, we're going to talk about that.
Okay, thank you.
I'm going to page 9. I think this page is the same as what we've seen in the past. Anybody want to pull anything out on page 9? Oops. Delegate Lewis Young, did you have something on page 9, or is that still for page 8?
Sorry, I didn't put my hand down.
That's all right. All right, going to page 10. This is essentially the same that we saw the last time. Anything on page 10 that anyone wants to pull out? Seeing no hands. Page 11. Page 11. So in page 11, what we did on lines 21 and 22, because that was an area that folks had concern about, we again referenced the financial assistance policy that we established earlier in the bill, saying there had to be that signature saying that I've heard about the financial assistance program. So anything on this page? Okay. Page 12. So when we did a careful read of the bill and what existed in previous law, we noticed that the hospitals actually had to send out a certified mail. The one notice had to be a certified mail billing statement. And so in order, part of the affidavit to go to court would have to be a piece of or documentation of the receipt of that certified mail. So that kind of gets to the issue of reaching people who are may not have either may not have the computer portals that they were talking about, or the or be available by phone. Any questions on page 12? Delegate Krebs.
On that one, so you're saying that if somebody doesn't sign for a piece of certified mail, that you can't move forward with something? I mean, many times people don't want to sign for certified mail, or they can't because I don't, they don't go to the post office to pick it up or whatever. It seems like a high bar. I don't know if the hospitals have anything to say about it, but it seems like a high bar.
That's not what it says.
It says it's a copy of the patient's signed certified mail acknowledgement of receipt of the written notice of intent to file an action. Patient signed certified.
Right. So earlier in the bill on page 9, in lines 21 and 22.
Mhm.
So there's notice that's required when a hospital is going to collect on a debt. That requires them to send the patient this notice by certified mail.
And first class mail. Okay.
Right. So what is this new amended language is saying, if they receive that copy, that's something that the hospitals would then provide, along with when they went ahead and filed a complaint. That would be additional information that would go along the complaint. And that's their way of saying, look, you got this notice. If the-
Okay, so it's not required that they have to get the certified notice to move forward.
No, it's if they got it, that can be part of the information that's
Right.
Receive. Okay.
collected.
Devin?
Mhm.
All right. I just want to make
Okay.
sure that it doesn't have to be in order to move forward. Okay.
No.
Okay.
Okay.
Madam Chairman, on page 12,
Okay.
line 10, is the hospital required to send a copy of the notice of intent to file action? Is that
Yes.
before? So they're required, and I'm sure we can later when we do this whole bill, we'll just go through the timeline and all that. But that's part of the sequence. Before they can file, they've already gone through all that, and they sent them a copy for intent, and they tried, and they still at that point haven't been able to collect.
I haven't been
Correct?
able to reach them. Right.
Okay.
Okay.
Now, what I'm sorry, on line 17, and I know you must have covered just now, but it's still in there. It says a copy of the patient's signed certified mail. What if they say I didn't get it?
Well, that's what Delegate Krebs was just asking about.
Right.
This is not an absolute requirement. You have to have this. You can't collect it unless you have it. It's one of the pieces of documentation the hospital may have in order to
Okay.
move forward.
Okay.
All right, so, all right, 13. So we've added some things in line 9, and we're looking for a February report that the HSCRC would complete, where they've compiled all the information that we've required of them in the beginning, and prepare a medical debt collection report. And the report will be made available to, you can see that, I don't have to read that. And it'll be submitted each year to the Senate Finance Committee and HGO in accordance with the state government article. So this is where we'll get the information on what the impact of medical debt is on, and we'll see here what the impact of high deductibles are. This is further about the study, what the study that is reflected above. And then one of the things in the conversations that I was having over the weekend was that our CRISP, our health information exchange, is a depository of information that could potentially be used to support hospitals in determining eligibility. And so that this kind of thing could happen more quickly. And I'll remind the subcommittee that right now, the health benefit exchange, if someone puts a check on their income tax saying that they didn't have health insurance and they'd like to have health insurance, can they get information from the exchange? The exchange can, in very short order, if given permission, determine eligibility for different, potential subsidies for insurance. This would be the same kind of thing, only for hospitals. The exchange doesn't work, doesn't have any purview or authority over hospitals, but the Maryland Health Cost Commission, MHCC, does, and MHCC is the has oversight over CRISP, so we can look at that. We just thought it might be worth exploring, because one of the things that we learned from the report that the that HSCRC did last year was that we do have folks who would have qualified for free care, but were not caught and ultimately ended up being charged or brought into collection because they were not identified soon enough. So that's what we're trying to avoid with this. Okay, so
Madam Chairman?
yes.
Quick
Delegates,
does CRISP has the information?
it doesn't have the financial information. We would have to give them, they would have to have the permission to do that. But again, it's a resource that we could potentially use.
Right, wouldn't that like delay determination though, or eligibility?
It would actually expedite it. If they agreed to allow their information to be used, if the person agreed for it, it would expedite the process.
Right, but what if CRISP doesn't have the information? Because I don't think CRISP has the information.
The patient would have to agree to give CRISP their information. So
Okay.
yeah. So again, it just makes it easier for them that instead of having to gather all this different kinds of documentation.
So what about the privacy? What about privacy?
They could choose not to do it.
And what happens to the collection if they choose not to do it?
If they believe that they're eligible for financial assistance, then they've got to complete the process that identifies them as eligible for financial or for free or reduced care. So they can do it, again, this is an exploration. Let's not go off on,
Okay. All right.
We can talk about that when we talk about whether or not it's even feasible. It may not even be feasible. It's just something that we were thinking about.
Right. And one last thing, on page 13.
Okay.
Just to put on the side, the effective date seems to be too soon. So we want to talk about extending a little bit into earlier in 2022. But we can discuss that later. I wanted to carve this off to the side.
Okay. Okay. All right. So let's go back and talk about the areas of concern. And I think I go back. Okay, I think we didn't start here till 6. Okay. All right. So I think we were all in agreement up until page 6. And page 6. Did I miss something?
Yeah, Madam Chair.
Okay, Delegate
Before
Bandari.
you go, could you put one thing in the parking lot, since we are skimming through now while skimming through this document, I've seen that the reduced cost has been omitted or deleted throughout the document, and there are in few places. And could we revisit that as well?
We can, yeah.
Sure, thank you.
Delegate Morgan.
I believe Delegate Saab asked the question that I was going to raise when we were on page 13 on the back about the effective date of this. I wanted to know if the hospitals could actually comply with it going into law on I believe it said February or January 1st of this coming year. My second question is, what do the hospitals do with people that fall into this category currently? Do they just get swept into the system when this law goes into effect, or they,
So first of all, the hospitals have never made an issue of the enactment date. So they apparently they believe they can do it within the dates that we've given them. Or at least because that date's always been there. what this bill would do is halt all collection processes right now until they have their plans developed and approved. And we're shooting for a November 1st date for that. And then the anything that was in progress could be resumed after that, under these new guidelines and under the payment plan, payment plan policy. Does that answer the question, Delegate?
I think so. Are we on the bill now, or are we still?
No, not on the bill, because there's some outstanding areas that folks want to discuss.
Madam Chair, you mentioned about on the date. We'll go back to the date. I know that effective date's been there since the beginning of time, but we've made a lot of changes in the bill of things they have to do. And when you look, we'll go back to the page we're getting ready to go to is page 6. You talked about on or before November 1st, each hospital shall submit and obtain approval from the commission of. So let's say that's the date they finally get approval. Then they start to enact the policies. It's November. It could possibly be as late as November. So how do they have time? I'm concerned about that. November 1st, you start to enact the policies. Then you got till right now it's October 1st, but you have until November 1st to get the policies approved. So the October 1st date comes before the November 1st date. It doesn't seem consistent.
So what the hospitals have said to me is that they all currently have payment plans in place. So what they would have to do is start with what they have, make sure that they've included their advisory committee, and make sure that they're addressing each one of the guidelines that we have identified.
It says here on page 6, a hospital may not collect on a debt until the hospital has established and implemented the plan that's in accordance with the policy developed. Right. So they can't continue what they're doing. They got to sort of stop what they're doing.
I mean, if this is not a silver lining, absolutely, but the hospitals have not been collecting over the last year. So because because of the COVID. So this would just continue that until November. We're kind of keeping a status quo until November or whenever, if they got their plan turned in on October 1st and it was approved by HSCRC, they could begin as soon as it was approved.
And I understand what you're saying. Many people have been impacted terribly by the pandemic, and there's many people that have not been impacted with medical issues at all because they've maintained their insurance, they've maintained their jobs. So we're like basically saying everybody's the same, not just somebody that's out of work or out of their insurance, but even somebody that has the resources to pay it, everything is on hold. And I don't see why there's not a differentiation, because many people haven't been impacted. And you're putting this stuff off, and the longer a debt goes, but without being collected, the less chance you have of collecting it. And then that goes into uncollected debt and uncompensated care. And there are people that really should be starting on their plans and can be starting on their plans.
So I did check with HSCRC to see what impact that would have on them, and and they believed that it was doable to wait. So and I don't know how we would differentiate between those who can and those who can't at this point. I think we just need to make sure that the payment plan, if someone is currently paying on a payment plan, they would be continuing to do it. What this stops is any activity towards collection at this moment until the plan is in place.
Well, if you knew that, why would you pay? But and again, this will be going on. It's going to be going on 2 years. Because this year and then, it'll a year and a half. It seems like.
No, I understand, but I checked with everyone I knew to check with to see what the impact would be on the overall cost of care if we waited until these plans were in place.
Okay.
Madam Chair, are we talking about the entire bill now? Or, I'm sorry.
No, we're still talking about. I'm going to go back to the pieces where people had issues. So the first issue folks had was having the hospitals independently develop their plan based on these guidelines, and in consultation with their advisory committee, to develop their income-based payment plan. So so I'd like to open that up for discussion now. That's what we're talking about now.
Talking about page 6 or page 7? Are we on page 6?
I think it starts on 6 and it goes to the next page. Let's see. It starts on 6 and underline 22, and it goes down to 7, down to page 7, to line 23. So this is the part we're discussing now. Delegate Krebs, I think your hand's still up. Delegate Bandari.
Yeah, thank you. On page 6, about the commission, it would be better if the commission, shall convene a work group to develop a policy for a payment plan offer under that subsection in the work group shall include the one member from Maryland State appointed by the President of the Senate, and delegate by the Speaker, one member from the Office of the Attorney General, one labor union comprised of public sector healthcare workers, one labor union comprised of nurses, one statewide nonprofit consumer rights organization, one patient right organization, one legal service provider who works with medical debt patient, one legal service organization that focus on health and social disparities, two health economists, and two community members who have been directly impacted by medical debt from geographically diverse part of the state.
I think that what we're trying to do is make this this process as streamlined as possible. I understand the need for stakeholder input, but I believe that we accomplish the stakeholder input in the patient advisory committee that the hospitals have. And I don't know, Erin, were you able to find out any parameters around the advisory committees?
I did. It looks like the ones that are in statute are more directed towards individual patient care. So it might be something we need to look back to in terms of if there's a group they could consult with in making the plans, or if just the fact that they already do have existing patient plans, payment plans, and whether the provisions of this bill, they could modify their plans to align with provisions in the bill, and then the requirement that the HSCRC approve those plans.
So if
so we'd have to look at if there's some sort of stakeholder involvement in redoing the payment plans, or if the guardrails in the bill plus the HSCRC review of the plans and the deadline for the date would be enough.
So the stakeholder group that you and I spoke about Erin, I'm looking at you. Would it be possible for each hospital to compile a group of those representatives?
And it's always possible, but you'd want to circle back with the people.
Right.
I mean, it's a policy decision for you all to make, of course, but
okay.
It seems like there's people on both sides of that.
Right. Okay. All right. Well, we will. Trying to think. Was really hoping we could finish this bill today, but.
Madam Chair, I have a question. It's a little more general, and as I'm thinking of this, before it goes into debt, does the people, the patient or with a family, do they have a chance to even question what the debt is? I mean, I know it's the rates of being in the hospital, but all the things that go with it. I mean, is there any kind of appeal process or arbitration process of actually what the debt is, not how they pay it, before you get to that point? Is that somewhere else?
Well, it's in statute. You appeal to the Maryland Insurance Administration and your carrier. And so the carrier would be your advocate in appealing the charges of the hospital.
But a lot of people now have these high deductible plans, and that's why they're paying more attention to it, which is, I guess, a good thing. So depending on your insurance carrier would be your advocate for the actual charges and what is allowed to be charged. And what if you didn't have an insurance carrier? I mean, I guess you're up the creek to basically argue, hey, this is a $20,000 bill. And so it's really all through your insurance carrier before you get to the debt part.
Well, that's the issue, though. I mean, that's what we're trying to determine, right?
I think there's people, though, that it's not just about the debts amount. It's another issue, but sometimes it's the actual bill itself. It's not, and I might be getting off track, but it's basically, hey, they argue what the actual debt is and then their portion of it. But talk about that later.
Okay, Delegate Lewis Young.
Thank you, Madam Chair. I think I was one of the people that suggested we relook this section. And I certainly understand your point about communities are different and therefore the hospital's policy needs to reflect that particular community. And I could live with that as long as we could find a methodology for ensuring that the advisory board also reflects the demographic composition of the community. I know our community action agency has a federal requirement because they receive federal funds and state funds as well, that the board must be diversified and reflect income challenged individuals. So that might be an example. I don't know what the best example is, but I think there's probably a way to address that.
Thank you, Delegate. I'm wondering if it was in consultation with the hospital's patient advisory committee, which is represented by people who have been patients and who are members of the community. Would that get to the issue?
Well, I don't think being patients is enough. Maybe being patients that had they'd have to have at least some representation of individuals that have had these kind of financial challenges and understand the nature of the problem.
Okay.
Everybody, but a certain percentage.
Okay. So yes, so can we try saying this, that the Patients Advisory Committee, which will include community members and members who have experienced medical debt, and the Board of Trustees can sign off on that advisory committee. Does that work?
Yeah, I think so.
I mean, I'm sorry, what would that accomplish? And I'm trying to figure out what Delegate Lewis Young is trying to say here.
Okay, to be perfectly blunt, I don't want the advisory committee to be made up of people with household incomes of $250,000 a year. I would like some representation of people that experienced or are very understanding of economic challenges.
No, I understand that, but we're going by income, we're not going by emotions. We're going by data and facts. We're not going by what.
Hold on, delegates. We're gonna, I think we're clear on what the issue is, and I think we may have a possible solution, which is if we put in the line in consultation with the Patient Advisory Committee, which includes community members and those who have experienced medical debt, and representatives who have experienced medical debt shall develop an income-based payment plan. Does that work for folks?
How are you gonna find them? I mean, I thought there was privacy. Not everybody knows who's experienced medical debt.
Well, the hospital would know.
So
The
they will
hospital could
email
reach
them or
out to
call them
folks.
and say, would you like to serve an advisory since you were in that position before.
Sure.
I
Um,
honestly don't think this serves I mean, I probably would not support something like that. I don't think it serves what we're trying to do with the intent. I mean, I think
Okay.
if you don't have to be, a criminal to be on a jury duty, to feel the same way a criminal would feel. And I'm not comparing that to crime, but I'm just trying to rationalize the thinking here.
I made a reference to the Community Action Agency. What they actually do to make sure that the board is diversified is recruit former users of the Community Action Agency services.
Okay.
But they might recruit, but they don't actually have to have the requirement.
Oh.
That's a completely different thing.
They have the requirement in order to receive federal funding. The board has to have diversity on the board. Yes, it's a requirement.
Diversity by income?
No, diversity by actual users of the service.
Okay, I'm going to go to Delegate Bandari.
Yeah, on the same line, I'm wondering if we could, that's wonderful plan, but in the meantime, if we could include at least one statewide nonprofit consumer right organization there so they could advocate more. So that's my proposal.
Okay. I would want the hospital to be looking to its own community. Not, I mean, consumer advocacy groups can be engaged in the hospital community, but to have them on this advisory committee, to require them to be on this advisory committee, I think would be a challenge. Delegate Krebs?
Well, sorry, two things. First of all, this advisory committee, you're asking to do a lot of things and you don't even know if anyone has any expertise in any of it. So it seems like it's going to be more driven by the administration, because if you don't put people on that have this ability, this is complicated stuff. It's complicated for us to even look at this bill, and you're talking about advisory committees coming up with plans. I think it's going to be a challenge, but you keep talking about income. Do they look at assets either? Because just because you don't have income at a certain time, people have lots of assets sometimes. Is it looking at both assets and income when you get these payment plans, or you get that uncompensated care?
We have been speaking of it as in terms of income based, so that when you're paying back based on your actual income and not tapping into your other assets.
But there are people that have substantial assets that might not have income coming in at a point in time. And it seems to me that's really short-sighted. You got people with a lot of wealth that might not have actual income year to year. I don't know. When we just use income, there's a lot of people out there have different kinds of income, and it's not just earned income in there. I mean,
Yeah.
I don't
Their
understand
assets
that.
might not be liquid though.
People have, well, you don't know until you see it. Doesn't matter. I mean, you've got a debt, and if you pick to have a $5,000 high deductible plan, in my opinion, you should be able to at least pay the $5,000. And many people that do that do have wealth. So you're literally saying to those people, we're going to look at your income and not the ability that you do have wealth. I just think we're tying the hands of, and you're people, you have a vision of who these people are, and there's lots of diversity in the kind of people that these could be. Whether it's in a state, we haven't gotten to that part, whether it's in a state, maybe it's in a state of somebody's got millions of dollars, and that's another whole issue, but you've got this one kind of person in mind, and there's people that have immense wealth that might not have the income that you're talking about. But I think
Okay.
I just think the people with the $5,000 deductibles don't have the money to pay the premiums on the lower deductible plans.
it could be people that don't have a lot of health issues that are willing to take a risk too.
We're gonna become a little more organized in this. So I'd ask for folks to use your hands to let me know that you want to speak. We are speaking now only on the how we can agree, or if we can agree on whether or not the hospitals will develop the payment plan policy. Delegate Morgan.
Thank you, Madam Chair. My question was on that, it had to deal with all the dates that are in the bill. Let me see if I can get to a copy here where I can actually read. It talked about 180 days and then 60 days and then prior to 60 days to release, well, I think it was 180 days from the initial patient billing. Do all those dates actually line up logically? I'm trying to put that into comparison to some other legislation that we've done in the past. One, the HFAM bill that required like payments within the first 90 days to determine Medicaid eligibility. I didn't know if that's consistent. It seems like it's a very long period of time.
It is a long period of time. Federal law gives 240 days. So our timelines are within that 240 days. And so hopefully by that period, we would know whether or not the person was eligible or not. I think the other thing to remember is if your status changes within that 240 days, you can apply for financial assistance or reconsideration of your status. So that's why the timeline is so long. And I think it's a part of hospital costs being so high. So the timelines have been worked through with hospitals and then what we know about the feds. Delegate Saab.
Delegate Morgan actually addressed my question. I mean, I still have something on timeline, but he did ask my question. I'll wait till the next round. Thank you.
So in an effort to see if we can move forward, would there be a willingness to go back to my language that said a patient advisory committee that includes community representatives who have experienced medical debt? Would that meet everyone's, would you be more comfortable with the hospitals developing the policy with them on the advisory committee?
Can you tell me what page you're on, please?
I'm on page, is it 6 or 7? It's on page 6.
Okay, oh, sorry. Thank you.
And it's after line 22. Okay, let me ask this question. Those who would be comfortable with, who would be uncomfortable if it didn't meet their needs to add, to say, patient advisory committee that included community members who had experienced medical debt. Anyone who would be uncomfortable with that?
I don't think it's necessary. I think it's, I mean, I think the hospitals want to collect money. I don't think it matters if you've been in someone's shoes or not. We all have been in uncomfortable, situations before. I don't really think this really adds any substance to, the way that the advisory committee is made out of. I think the advisory committee has, good intentions to come up with the best outcome for the hospital and for the patient, because at the end of the day, the patient want to pay their bill or not have the debt, and the hospital want to collect as much as they possibly can. So I just don't really think it's necessary.
Okay.
Madam Chair.
Delegate Sample Hughes.
Sure. Thank you, Madam Chair. So I agree that there needs to be someone at the table that has experience of financial hardship and can have a say in the conversation, because my experience from being years ago on the county council, pretty much everybody up there a few of them were millionaires, and they could not relate to the hardship of some individuals. And so bringing that perspective to the table is, I believe, very important. The last thing I think is what kind of going in the dark right now is that we don't know for sure what's the makeup of any of these advisory boards right now as we speak. And if we had that as in our pocket, I think that we could say what is missing, what is necessary. They may already have somebody on an advisory committee. We may be redundant right now. So I think that's the important piece. And in the suggestion, I think that Delegate Bandari said, based on the consumers that spoke about this, there was one section that said one legal service provider who works with medical debt patients. So that person very well could be someone who understands, but I really prefer it be someone to be who has had that experience and can have a voice at the table. Thank you, Madam Chair.
So are you recommending that we add that that category to community member who's experienced medical debt?
Yes, I think that's probably the best that we can do right now, given the fact we don't know the makeup of the boards, the advisory committees that each one of these hospitals have.
So then if we did, advisory committee, including those who've experienced medical debt, and a legal representative, I mean,
Legal service provider who works with the medical debt patient.
okay. Okay. All right. Can I get agreement? Okay, wait, we've got hands here.
Couple questions.
Delegate Morgan.
Thank you, Madam Chair. I'm scanning through the bill real quick. How many people are on the advisory board?
I don't have that information.
So is this the
I don't
only?
think it's, now there is a board of trustees, as Delegate Louis Young told us about earlier. So that group would also have oversight over the development of the plan. And that group includes, community members and business, local business people and things, things like people like that.
Okay, so this language that we're talking about here, in theory, that we're trying to draft, that's the only requirement on the people to serve on this advisory committee, correct?
Right, exactly, to develop this plan.
All right.
That's
Here's a question. What happens if the hospital can't find anyone to serve? Just out of curiosity.
I hope that wouldn't happen, but they'd have to go to I guess we could ask them to go to the HSCRC and ask for an exemption.
All right. And how would that, if they couldn't find somebody, how would that impact them in this bill as far as having approval and everything else? Because that would be a logjam, correct?
Well, if they asked for a waiver because they couldn't find that, because they made an honest and good faith effort to find somebody to serve on the advisory committee, that's number one, and they can demonstrate that, and they've asked for a waiver from HSCRC, it wouldn't affect their ability to develop the plan because they would have gotten the waiver.
Okay, gotcha. Thank you.
Delegate Kerr.
Thank you, Madam Chair. Just a suggestion possibly is if we could take your suggestion for board membership and then combine it with the Speaker Pro Tem's suggestion and make it an or, which might also address Delegate Morgan's concern.
Making it or instead of and?
Yes.
Go do that. So, I am open to that. If that will get folks to where we need to be. And so Aaron, I don't see everybody. Aaron, if we were to add the language about community members who have experienced medical debt and a legal counsel who has worked with medical debt consumers.
Or a legal counsel.
Or legal counsel. Okay. Is there anybody who can't live with that? Say, actually,
Chair, in general, I'm thinking, I've been on many boards and we're putting so much stuff in this advisory board, but we're not looking at expertise. We've got all this diversity. We've got people that have been, somehow they've got to do a job. And we've got now how many hospitals? Every hospital is going to have a different board with different makeup, with different rules. And it's like,
Delegate Krebs, it's a committee. It's a committee
it's
an advisory. No, the advisory committee already exists. We're just adding to it. And we're only adding it for the purposes of making this plan.
I know that, but it's sort of a big deal. The advisory committees on some of these hospital boards do stuff more about patient satisfaction and those you're talking about very technical issues here that are not just about being a patient advocate. And you got all these specific things now that we have to have on this advisory board that's going to set these payment plans. And we're going to have 30 or how many hospitals we have different payment plans. it just seems unworkable to me what we're asking. And then what are they going to advertise? Say, how many of you have medical debt? Do you want to serve on this advisory board? I don't know. It just seems like the HSCRC maybe should be setting these plans and not all these 30 different, how many different advisory boards with different plans. I mean, what if you go to one hospital and you have debt at one hospital, then you go to the next hospital and your plan is different because you have a different plan at your different hospitals? I mean, there's no, I just can't imagine having all these different plans, all these different hospitals, depending on who sits on the advisory board. And they're going to be approved by the HSCRC. Why don't we just make the HSCRC submit the plans? They got to be approved. Are they going to be using some kind of a template to approve the plans? You know what I'm saying?
Yep, I do.
Madam Chairman, maybe just actually just listening to all that and as a suggestion, maybe to alleviate a lot of the concerns that many of us have, so we're not limiting the boards, is have that the hospital advisory board should or may include or make every good faith effort to include one of the following, but don't make a requirement. And at least they've made the effort to make it and then just move on instead of being stuck on, you know what I mean, like one thing. And if they can't get it, then they have to go to HCRC and get a waiver. Just have it as a suggestion that they should try their best to have some more diversity of thought, I guess, at this point we're talking, or life experience or income, whatever it may be. But at least they made the effort, but not as a requirement. So we're not tying their hands.
Madam Chair, I think we are forgetting the intent of the bill here. The intent of the bill is to protect low income and working families from medical debt that may lead to lawsuits. We can't forget that.
Right. No, I'm not forgetting, Delegate. We're trying to get there. I am still wondering, I'm going to go back to, and let's just take a vote on this. If we can get folks to, can we get agreement on the patient advisory committee that includes community members with experience with medical debt or legal counsel who have worked with medical debt patients? So
are you saying may or shall?
That they shall include one or the other. So now I'm going to ask for a vote. Those in favor of amending 3 on page 6. Yes. The way that I just described, please put your hands up in the participant panel. So now you're voting yes in the participant panel.
I'm sorry, I can't follow what we're doing, so I'm trying.
We're looking at the lines, each hospital in consultation with the Hospital Patient Advisory Committee, which includes members of the community who've experienced medical debt or legal counsel who works with consumers with medical debt, shall develop the payment plan.
So it's shall include and shall develop, right? Not
Yes.
may include and shall develop.
No, they're both shall.
Okay. I mean, I'm more comfortable with may and then shall, but I'm not gonna pick a fight over this. I mean, I think it's fine. That's
Okay.
what makes the bill move and come up with a good outcome, because I mean, that's not the real problem with the bill, is other things, but I'm fine with that.
Okay, so I have 8 people in favor.
And I don't Madam Chair, I don't disagree. I just think the HSCRC's got to have some kind of a template to say, here's what we're going to approve. And you're going to be sending this stuff in, and then, it's like hit or miss. How do you even know what they're going to approve? To me, they should be the ones doing this, or give you the guidelines, and there should be at least some guidelines that all the hospitals have to follow, and have some variations in between. Right now, it's like we don't even have anything to go by. I don't know.
Okay, so Delegate, we're in the process of voting.
I know.
And right now, I have 9 people in favor of the language that I've suggested. So I'm assuming if your hands are not raised that you are opposed to that additional language. Okay. Okay, so we'll amend that section in that way. And that should get us through that section, right? The development of the plan. And the next part, the next question we had was lines 1 and 2 on page 7. And what we said is that the hospital has to demonstrate that it's attempted in good faith to get, to receive payment before it can file an action or delegate collection activity. So, and I think it was Delegate Saab who was interested in revisiting lines 1 and 2. So Delegate Saab, do you want to speak to that?
Yeah. I mean, I think it should be struck out because I don't think it's, I mean, having the inability to collect any money or debt until after payment has been attempted, I think it creates some problem because, like, for instance, if the patient does not respond to financial assistance, or they don't, they have no way of, knowing if they need a plan or not, if because some people just don't respond. It just happened.
Right.
So
I'm actually
the
gonna.
HCFC limited the ability to collect debt. Well, I think it would have some negative impact on some uncompensated care as well, and that's what I'm concerned about.
So hands that are up now: Delegate Lewis Young, Delegate Kipke, Delegate Card, Delegate Morgan. Are you all speaking to this issue? So what I'm interested in now is folks who want to speak to the issue of potentially eliminating lines 1 and 2 on the top of page 7. So we'll go with Delegate Morgan.
I think he was voting from the last round.
Okay. Delegate Kipke.
Thank you. Just so I know what we're talking about. What all this language is saying is before they go to collections, they have to demonstrate, based on their commission's plan, that they have tried to collect the debt through payment plan internally with the hospital. Is that right?
That's correct.
Okay, and so this line here, and then what about the statements that were, so basically what we're doing here is saying the hospital has to show that they've tried to get paid on their own through a payment plan, assessed whether or not they're eligible for Medicaid or some other payment mechanism, and if you've exhausted that, then you're allowed to move forward with debt collection, right?
Correct. That's exactly right.
All right, and the vendor in line, Roman numeral number 2, the vendor could be the debt collection agency. It's just they can't move forward with debt collection, right?
Correct.
Okay, thank you.
That's what we tried to address there.
Thank you.
So let me ask the question. Is there anybody else who wants to speak to Delegate Saab's recommendation that we eliminate lines 1 and 2?
I think that should be there. Okay.
No, right. I think it should be eliminated because right now it's going to tie the hands of the hospital to even talk to the people first. I mean, I would hope we don't even have to get to all this, that there's some discussion. You're tying their hands to even be able to call and make contact with somebody until they have a payment plan. So there's the inability to collect any outstanding debt to even make the calls. I mean, some of it might be able to be worked out before that. You're basically tying their hands.
Okay, so I'm going to ask the group now. If you are in favor, listen carefully to the question. If you are in favor of deleting lines 1 and 2 on the top of page 7, please put your hand up in the chat.
I mean, I'll just say, I don't know. I don't know what the point that Delegate Krebs just made is, you know, I would like to run that past somebody who does this at the hospitals to know if there's any unintended consequences. I mean, it sounds good what's trying to be accomplished here. I like the idea and where it's going, you know, basically to kind of protect people and not just jump right into collections. I'm not opposed to that at all, but I just want to make sure that nothing is being, you know, there's nothing else going on here. So in concept, I like the idea. I just want to kind of verify it before I'm held to the vote.
So what the hospital said to us was that they use the debt collector as the as the agency to determine eligibility. And what we're saying is that's okay, you can use them, but you can't collect on a debt until you have done your due diligence around trying to get the payment plan done. That's all that is.
I should be at the right site because I clicked on the link you sent me.
But how would the hospital know if a patient does not respond that this patient need financial help?
You're right, Delegate. The hospital wouldn't know, but if the hospital has worked in good faith, then they would have made the effort to. They would have made every effort to try to reach them, and they could start the collection agents because they've operated in good faith and they've filed an action to collect debt.
Right, but this when they're collecting, which means they've already had multiple. I mean, how many days at that point have passed? I mean, I know they've gotten what, 5 or 6 statements. I can't remember exactly. It was like this is like almost 6, 7, 8 months down the road that someone knows if you went to the hospital that something is coming. Like it's not like you just get a surprise call like, oh, you owe money. They've already been received. They already have received multiple bills. So this isn't the first attempt.
No, it's not the first attempt. It's, you know, you're right.
Right.
It's they've been many attempts to contact the person.
And at that point, that person, they should know if they need assistance or something. At that point, they would, you know, state that. So that's why I think removing it. And the biggest thing is also the what this would contribute to uncompensated care, because if you can't collect at all, we're tying the hospital's hand of collecting any money. And I think we just always forget the hospital job is to provide care, not to collect. And I think that affects the budget, not the budget, but it just, there's a lot of money that's going to get written off for uncompensated care, which at the end of the day, we, the taxpayers, have to pay for.
I understand.
Like the language is awkward. Maybe we're reading it differently, because the way I read it, you can't even attempt to make, if the patient doesn't respond to financial assistance for this care, the hospital has no way of knowing that it needs to set up a plan. So I think maybe it's just we're reading it differently. I don't know, but the way it's worded, I read that they can't make any efforts until they set up a plan. We don't know if you need to make the efforts until you've contacted the person. What comes first, the chicken or the egg?
Well, all the effort that they've made to outreach to the patient is the part that comes first. And when they can't reach the patient, then they have sent out numerous different notifications and still no response. They've done their good faith effort. And at that point, once they've demonstrated that good faith effort, they can file an action to collect a debt and they can put them into collection activity. That's what that means. It doesn't mean that they can't ever do it. They have to make sure that they have met the good faith effort requirements in 6.
It says of the commission. So that's is something the commission's going to do, or it's what's in 6?
So I think, Delegate Collison, if you don't mind, that's a carryover from before when the commission had to approve the payment plans. that it could be rewritten to say a hospital shall demonstrate that it attempted in good faith to meet the requirements of the hospital's payment plan.
Oh, okay, because that's what I couldn't
File.
figure out, because the commission, it says the commission is creating, it didn't say that, okay.
Okay.
Yeah, I think it's a carryover from before when we had the commission develop.
So what did you just say, Aaron? It attempted.
So a hospital shall demonstrate that it attempted in good faith to meet the requirements of the hospital's payment plan
Right.
before the hospital
Can. Does that help?
The hospital shall demonstrate it attempted in good faith to meet the requirements of the hospital's payment plan.
Right.
I mean, I guess the whole thing about, excuse me for seeming stupid, but there's attempts before you make a payment plan. You just reach out. So what, I guess the definition of what the payment plan is, because there's an official and an unofficial payment plan. Unofficial means you call them up and you say, hey, can you make, I don't know which comes first. It seems like they were tying the hands of them to collect early on in a more informal way until you, in doing that versus you're taking away the ability for them to collect early before the payment plan and their hands are tied. I'm just maybe reading it that way, and I just don't know why we'd want to do that.
I think
that's what it's doing.
Yeah, but they're going to have attempted to create a payment plan by reaching out to the person. If the person is not responding, they've made the good faith effort. Then they can send it into collection.
Okay. I guess if they haven't reached the person yet, they don't really know if they just haven't reached them or they can't pay. You know what I'm saying? If you've never made contact.
I understand, Delegate, but it's just, we've got to at some point draw, this doesn't put the hospitals at any disadvantage. They get to do the collection activity as long as they have sent the proper notifications, the person initialed that they indeed got the financial assistant policy. So, they can do it as long as they've done those things in good faith. So I'm asking the question again. Folks who believe that we should strike lines 1 and 2 on page 7, please put your hands up in the participant panel. Okay, that does not have a majority. So we then said, let's look on page 7 at lines 16 to 22. And I think this was you, Delegate Krebs.
Page 7.
Delegate Krebs, you're on mute.
I'm sorry, what did you say, Madam Chair?
I thought you raised the concern in lines 16 to 22. It was you or Delegate Saab?
Page 7, I did.
On page 7?
Page 7, 18 to 19.
16 through 22.
Well,
it was the same thing, the delegate collection. Yeah, I mean, page 18, it says against the non-payment or delegate collection. It's the same issue that we talked about up there. It's just, I think it continues. They may not report adverse. I think that's what you're talking about by removing, but it's the same thing. We didn't remove up there, so.
Same issue. Okay.
That's when you report to the credit agents, I guess.
Okay.
I have a question.
Delegate Kipke?
Thank you. So I understand if somebody should be signed up for Medicaid or free or reduced care, but if someone's uninsured and they have the cash to pay for it, how does this section relate to them? So, there are people who can afford health insurance and just choose not, they'd rather buy their BMW and whatever, like what about those people? Are we going to let them off the hook here? I just want to make sure.
If they're in a formal appeal process, that's what they have to notify the hospital of. So the formal appeal process will be, well, it won't be with their carrier if they're uninsured. I suppose that they could go to the, they could go to the Attorney General's office to make a grievance against the hospital.
So
But
this section is just for people who are appealing somehow?
right, this part right in, well, I'm looking at 12, right, at 16 to 22, yes, it's for people who are in a, who are in an appeal process. Sorry. Does that answer your question, Delegate?
I'm looking for the, I'm glad we're gonna have a chance to read this bill before we vote on it. Read it thoroughly. Where is the appeals process language? I'm trying to find it quickly, not to hold everybody up.
In the notification packet that the person gets upon discharge, and also in each notification that they receive, there's a notification saying you can appeal these charges.
Right, no, in the bill in front of us, where is the language that says this piece of it is related?
Go for a walk? Let's go for a walk.
Lines 20 through 24.
20 to 24?
Yeah. So the hospital cannot report and
I
then
see it.
saying if.
Thank you. I got it now, thank you.
Got it? Okay. So Delegate Saab, is it on this question or is it on this page?
I think what we were talking about is on page 7, line 18 and 19. If that's what he was talking about. It just, well, no, I'm sorry. I'm on the wrong page. We already talked about that one.
Good.
You're on page 8.
We're
We're
on-
on page 8 now.
We're on page 8 and lines 23 and 24 were raised.
Mhm.
And lines 21 to 22, which is what we just discussed.
Okay.
Okay. Have we resolved those issues?
Well, what did we say about line 21 and 22?
That individual has to let the hospital know that they are in a formal appeal process.
Okay, so we're just keeping that there, line 20. Okay, so on line 23, 24, it seems to me, I mean, there are people that have resources, and just because a lot of people die in hospitals and they leave debt. And if we wipe out everybody's debt just because they passed, they might. So I would think it would say something about if with the exception, they can go after the debt unless the deceased patient was known by the hospital to be eligible for free care. And then, looking at the value of the estate after taxes obligations are fulfilled, that they should have to pay something. The hospital should offer the ability for the family of the patient to apply for financial assistance, but just to let everybody off that passes in a hospital or passes soon after being in a hospital, it's they might have the resources. I'm not sure if insurance still covers things, but I don't know why that would be the case, because they might be wealthy. They might have plenty of ability to pay.
Okay. I have Delegate Saab, Delegate Lewis Young, Delegate Kipke. Are you all on this section here, lines 24 or 23 and 24?
Yes.
Okay, and we'll go with Delegate Lewis Young and then you, Delegate Kipke.
Thank you, Madam Chair. Actually, I'm on line 21, 22. I had to leave the room for a minute.
Okay, hold on. So 21 and 22, we're not there yet.
Okay, thanks.
Delegate Kipke?
It would look like we passed by it, Delegate Young, but
Yes.
we knew we
Okay.
couldn't slip that past you.
Okay,
On line 20,
just checking.
24, I share the concerns that was brought up by Delegate Krebs, and I have an example that, I had a relative die recently, kind of unexpectedly, and he owed some money, and his brothers and sisters are going to have to pay it out of the estate instead of them pocketing it. And so, you know, I don't think it's appropriate. I mean, I feel for I forgot the guy's name that testified. You know, it's really tragic that, you know, especially if he was living in that house. And I know there's discussion about generational wealth transfer and all that. But just remember, every dollar that doesn't get collected makes everybody's insurance more expensive. So there's also generational affordability of health insurance. So we have to be responsible about how we do this. And, you know, I would just, you know, find it with all that we've expanded Medicaid, which I voted for at my own political peril, you know, the expansion of the Affordable Care. I mean, we're just doing so much to make health insurance more affordable, but people have to make the right decisions and have personal responsibility. If you're in a situation where you're not going to be able to pay your medical bills, you're taking on the risk that the next generation isn't going to inherit any money that you may have. So, you know, I think we need to leave that in the bill. I think it would be inappropriate to make all ratepayers pay for the uncollected debt.
Delegate Lewis Young, did you want to speak to this piece or no?
No, sorry, I left my hand up for 2122.
Well, let me ask the group then. Those in favor of retaining 21 and 20, no wait, I'm sorry, 23 and 24, I'm sorry, striking 23 and 24, please raise your hands in the panel. So if you want to strike 23 and 24, that's what we're doing a straw poll on now. Okay, that's not achieving a majority. So we'll go to 21 and 22, Delegate Lewis Young.
Thank you, Madam Chair. This is an issue that really is at the core of this bill, I believe, that a hospital may not file an action against a patient to collect a debt owed on a hospital bill, an amount less, an amount of 1,000 or less. I'm going to ask if the committee would be willing to compromise on an amount of 500. I believe that's a reasonable compromise. It protects the most vulnerable individuals. And quite frankly, I think it's a good business decision for the hospitals because based on not only my experience, but my research, which would suggest that for debts under $1,000, less than 50% is collected because 50% goes to collection fees. So I'm going to ask the subcommittee to consider that compromise.
Okay. Discussion on this part. Delegate Kipke.
I would just ask how many of those instances would there be and what the total dollar amount is. I mean, to some it might sound good to do that, but if, you know, even that, the advocates for this bill brought with them an economist study. And in that study, it even said that it could lead to more people not paying their bills. And I've mentioned on several occasions that I know several people who, whether it's a dentist's office or an eye doctor or a hospital, they end up in some type of payment plan or collections or sometimes court for whatever reason. I mean, that's just how some people roll. And, you know, and some people might be in a tough situation. But just remember, those same people are trying to afford health insurance as well. So if there is an increased amount of uncompensated care that could otherwise be paid by the people who are using the service, I would say that that would be a bad public policy, especially in light of the fact that we've expanded Medicaid coverage, we've expanded subsidies in the ACA, and you know, we've done all these things to make it more affordable. You know, I just, you know, I get it if it's somebody who's legitimately poor and eligible for Medicaid, but I really don't get it for people like I know in my community who are, I mean, some of these folks, in my opinion, are just kind of irresponsible and don't pay their bills. I mean, just to be honest with you, you know, every once in a while you look at somebody's judiciary case search and you scratch your head thinking, well, you know, you have a new BMW. What are you doing? So anyway, I say all that sort of in the same line as the previous comments.
Thank you, Delegate. Seeing no other hands, I wanted to address this. This one is a tough one, but because it seems on its surface very reasonable. But I share the delegate's concern in terms of the overall impact. And we have information from HSCRC that says how much uncollected funds could potentially affect our total cost of care model. So the reason, or the way that I am justifying this with myself is to say what we've tried to do in this bill. Number one is to give people every single opportunity to sign up for financial assistance and to know that they have that available to them, and to know that that there is a viable, considerate, compassionate payment plan that's based on their ability to pay and not financial hardship. So for me, I'm weighing those pieces against this. At this point, I think, you know, we even heard, and I sort of addressed this on Friday, saying that, you know, it's one of those things where we are, you know, making policy for folks who aren't always following the rules. Because if we had any cap at all, it's an invitation not to pay that money. We even heard an example of that in our discussion from someone who probably didn't realize that he was giving us that example of that if I had known that I wouldn't have had to pay up to $300, I wouldn't have paid it. So I think, you know, I want to believe that the rest of the bill addresses the issue in such a way that those folks will be able to, even those who are over the 500 or the 200% federal poverty level, will have a payment plan that meets their needs. So that's why I would recommend continuing to strike lines 21 and 22. Delegate Lewis-Young.
Well, first of all, you're not advertising that you do that. There's no way that if you've got $500 or less in debt, you would know. And the hospital still can collect. All I'm suggesting is that if your debt is less than 500, the hospital can't take legal action. They could still attempt to collect.
I understand. Delegate Bandari.
Yeah, to that point, yeah, I do agree with Delegate Kipke and yourself. However, I'm looking like sometimes things happen, miscommunication, unintended consequences. And if they are being filed lawsuit, and this kind of is a cycle of poverty, you know, so it will affect their credit and million things might happen, you know, so then even that is more troublesome in a long run. But I don't think that people who, yeah, there might be few, but majority of them, if they need to pay, I believe they can pay. But there are few who might not be able to pay.
And I would offer, Delegate, that those are the folks we're going to catch in our increased efforts to identify those who need assistance. And I understand what you're saying, and certainly, I mean, remember too that this bill takes into consideration that your financial situation can change at any time, and at any time you can go back to the hospital and ask for a revision or reconsideration of your payment plan. So, you know, if something happens that you can't pay it any longer, then you have recourse. The person has recourse. Delegate Kipke.
Yeah, and just another thing that occurred to me, I'm thinking about certain people when I'm talking about this, but in some of these situations, you know, in all of these situations, the judge can look at, if you end up there, and of course, nobody ever wants to end up there. And if you end up there, it's been a very long time. But the judge can look at an individual's situation and determine how much needs to be paid. And it also can be done in, you know, not all at once as one big lump. It can be paid for over time. So the judge has discretion in situations like that. And of course, hey, maybe not all judges are going to be as empathetic as others, but I think generally when it comes to something like this with a hospital and somebody in a tough situation, they're usually a lot more empathetic than not. And I do think the protections in the bill, which I wholeheartedly support, which puts more of the onus on the hospitals to fully exhaust, you know, the options for people. I think that's a very positive step, and we'll ultimately see many fewer people ending up in the courtroom.
Delegate Kerr.
Thank you, Madam Chair. I would just like to voice support for Delegate Lewis Young's idea. I know that often there are ridiculously low amounts of that go into collections, and it shows up on credit reports, and it seems that there's got to be a number somewhere that below which it just gets to the point of harassment to send something to collections. Thank you.
Delegate Lewis Young, is that?
Yes, I'd just like to ask you, Madam Chair, if not 500, is there any amount that you would find acceptable as a cutoff?
At this point, no, because I want to give the bill a chance to work in order for us to see, you know, first of all, gathering data that relates directly to what's happening in Maryland hospitals. That's what this bill does. It puts in place the much more rigorous notification process. So let's try that. So I'm hoping that we don't need that going forward. But if we learn from information that we gather over the year, then we may have to revisit that. Delegate Kelly.
Thank you, Madam Chairman. Just a clarification, because I'm hearing two different things, one from Delegate Young and one from Delegate Kerr. So I just want to make sure I understand the question before us. This language would apply to the action that's being referred to is a court case, not going to collections. Because full disclosure, I am that person that Delegate Kipke, not literally the specific person he's talking to, but every time I refinance my house on my credit report, they're like, would you like to, you know, deal with this, you know, $25 in collections from your medical care? It always seems to slip through. It's usually the anesthesiologist for me, not the hospital. But regardless, my point is, while I agree with Delegate Kerr, that's not actually, we're talking about just the lawsuits, right?
Right.
Okay, and so we could, in theory, sort of test Delegate Kipke's supposition, you know, and look and see if we're seeing cases go down, because I think everybody wants, I don't want to speak for everybody, but I know that's important to me to make sure that we're seeing fewer of those. Right. So that's something we could look at over time. Is that what you were just saying, Delegate Cullison? The quantity of cases.
Okay. Thank you. Delegate Saab.
Thank you, Madam Chairman. So I guess I'm just trying to figure out exactly, is there an amendment before us, or is it a suggestion, or we're just going to keep everything the way it is and move on?
No, the suggestion is that we reinstate lines 21 and 22 with perhaps another number.
I'm sorry, what page was that?
It's on page 8. I think it's page 8. Yeah, it's page 8. And I'm asking the committee to give this bill a chance to work, and before we jump to that measure. Delegate Kelly, did you put your hand up again, or you just didn't take it down?
I actually haven't put it down, but let me just clarify.
Okay.
I'm eating ice, sorry. So when you're saying you want us to give it an opportunity to work, I think I'm just trying to connect the dots that, you know, if Delegate Kipke was suggesting that if we give this bill a chance to work, hopefully the other measures would have us seeing fewer people ending up in court. So what you're suggesting is let's look at it wholly as you're presenting to us, but as a committee, we will keep in mind that that's one of our goals. We just are not sure that having this provision in with a cap is going to be the best mechanism for getting us there while balancing the need to have less uncompensated care than necessary.
Right. That you said it very well. Thank you.
Thank you.
Okay, so I'm going to ask the question. Please be clear what the question is. I'm going to ask how many people want to reinstate lines 21 and 22, perhaps with a lower number. Okay, and I need to ask the opposite question now. How many people want to leave 21 and 22 struck? So now vote for. Okay. There are 10 of us. Okay. All right, so the majority is saying to reinstate 21 and 22, and Delegate Lewis Young, you were recommending $500?
Yes.
Okay. Okay, well, make that amendment. Okay, I think the next page was page 12, and it's line 10. Okay. And I'm not sure who raised that concern. Oh, wait a minute, I'm on the wrong page. 11, 12, okay, line 10. Can you tell me who raised page 12, line 10? That's a question?
Madam Chair, can I ask a question?
Sure.
Based on the previous question that was asked, the outcome of that amendment might ultimately kill the bill. I think people need to be aware of that. The bill becomes much more difficult to support a hard dollar amount exemption in the bill. And I'm just wondering if we can ask the question in a softer way, since this is an advisory committee, if that puts the bill in jeopardy, how many of the people who voted in support of that amendment would be willing to change their mind? Because I do believe it puts the bill in jeopardy.
Yeah, and I appreciate that. So, and I thank you for raising it, Delegate Kipke, because that is absolutely my concern. And I am worried that if we put the bill in jeopardy, there's no progress for any of these folks. And if we can get this bill passed without those two lines, then there will be a lot of progress for people who are low income and who have whose financial situation changes. Without this bill, then hospitals will begin to continue to do collections as they're doing, as soon as they can, as soon as everything opens up. So, I think it's a good thought for us to consider. Delegate,
I suggest after we finish, if we ever finish, before we vote in full committee, I think everyone, and I just sat back and read the HSCRC's testimony and also MDH, and I hadn't read it since the bill hearing. I think they give us a lot of information now that, and what Delegate Kipke just said is absolutely true. If you read the testimony from the HSCRC, it is a fine balance here between uncompensated care. This affects all this uncompensated care affects Medicaid rates because it affects hospitalization and affects emergency rooms and what they pay. So it's a very delicate balance, as you suggested, on many items. And this is one. We've already voted on it, but I suggest everyone go back and read and figure out the end result that we're going to have to look at. even before we vote, we should look at it, because I think that we have unbalanced things with a couple of items that we've done here. And it could compromise the ability to do what you want to do.
Delegate Kerr.
Thank you, Madam Chair. Yes, my goal here is to protect people who are unable to financially pay their medical debts, and if this would kill the bill, then we get nothing. So if that is the case, I would be willing to reconsider my vote.
Delegate Lewis-Young.
Thank you, Madam Chair. I would submit that the research, collection, and legal fees incurred in trying to collect small debt and go to court are probably as large, if not greater, than not going to court on a $500 debt. And so I would recommend that we take the bill as this subcommittee votes it to our committee, and we still have the possibility of amendment during committee with a wider audience.
I appreciate that. I would, and we would have that opportunity either way, you know, if we, so, and, you know, I know, you know, we are taking soft votes right now. This is just to give me an indication whether or not we can actually see this through tonight, if we can. So Delegate Saab, your hand is up.
Well, I was actually going to suggest the same thing. I mean, this is not, there isn't a real amendment before us. We're just, it's a straw poll to see what the subcommittee's will would be. So thank you. That's, yeah, I just want to make sure.
So Delegate Lewis-Young, did you want to say something in response?
No, I'm just a little slow taking my hand down.
That's all right. So just in the spirit of straw polls, let's take the poll of if you knew that this bill was at risk, if lines 21 and 22 on page 8 were reinstated with a cap, would you vote to, let's put it, would you vote to strike it? So it's the positive. Would you vote to strike it in order to keep the bill? In order to move the bill forward, would you vote to strike the lines 21 and 22 on page 8, the cap?
Are we raising hands?
Yep, use the hand function so I can count.
So,
Okay.
Sue Krebs, raise your hand.
You know, I really
Maybe
think
I don't
this
understand
is-
what you just said. I thought you said, do we want to strike it? We want to
Correct.
keep it. You mean, do we want to keep it struck, or do we want to strike what we just did?
We want to strike it. So we want to keep it struck.
Okay, not strike what we just did. I wanted to strike what we just did.
Right, we
Okay,
didn't do anything. We just took a straw poll.
I got you. I want to keep it what we have in.
Now the question is within the context of, you know, the risk of the bill. So that does get us just over the majority. And I'm sure that we will have this conversation in the full committee. But
Madam Chair, I apologize. I have got to leave. I was supposed to be somewhere at 5, and I really apologize. I cannot stay one more moment.
okay, well, thank you for letting me know, and I apologize that it's taken so long, but
Okay.
we really want this bill to have a life. Delegate Kippy, did you have is your hand still up or you have a question? Okay, all right. Okay. All right, so now, Delegate Kelly, is your hand still up?
Sorry, no, my hand is coming down.
Delegate Carr, is your hand up or still voting? Okay. All right, now we're going to page, I have page 12, line 10. 14. And I'm not sure who asked about this.
Is this with the date, with the implementation
There's no
date?
here.
So I had asked the question that possibly we can push the date to the effective date to January, to early 2022. Because I think to implement everything that's in this bill will probably take longer than what we had given the hospitals, because they could probably, adding this one and then also adding that the hospitals cannot collect any debt until the HSCRC approved the hospital payment plan. So it's just, I think it would affect the workflow with the hospital. And if we can just push the date a little bit to the beginning of 2022, which just delays I think it's 3 months.
Would the, how would you feel if the payment plan policy were still a target for November?
And we're only talking about like 2 months, just having it. I guess it's cleaner to have it all one time, because I'm worried about it affecting the workflow for the hospitals.
Okay.
Because these are big changes that we're making, and we just want to make sure that they have the time to do it.
Okay. Delegate Kipke?
I'd like to check in with them again about this, because if folks are, if no action can be taken between now, and I think you said when the payment plans begin November 1st, even another 2 months, that there's an economic consequence to that. On the other hand, they've got to be able to do all the work necessary to carry out the bill. So, I think we're all sensitive to all of that collectively, and we should probably really have them tap into their hospitals, find out what's the best way to go. Is it worth just waiting until a little longer and have them carry that unpaid debt? Or, I think we need to find out, honestly.
Yeah, I think we can, if the subcommittee is willing, we know that there are still some outstanding issues. So the question is, do we want to come back as a subcommittee, or do we want to just take it to the full committee now? With the knowledge that, with the exception, what I'm hearing is with the exception of the cap and the date, we're there on the rest of the bill. I didn't see the conflict. I didn't see any outstanding conflict except in those two areas. Delegate Kelly?
I would just suggest, if it's okay with the rest of the subcommittee, that maybe we can have that conversation in full committee. But, I really want to support what you're saying, because we could talk about this forever in subcommittee, but if it is going to move in some form, we need to get it moving.
Right. Yeah, that's what I was thinking. So, so let me ask this question. This question probably has not been asked before, but can we move? Well, let me ask Aaron. Aaron, I can't see her on the screen. Do we need a favorable or unfavorable vote in order to take it to the full committee, or can we take it to the full committee with the understanding that we have these outstanding issues?
I think it's a question for the chairman.
Yeah.
I don't recall. It would be the equivalent of taking the bill to the committee without a subcommittee recommendation, right?
Yeah.
Madam Chairman, I think, and I don't know why, I guess we would have been here all night if the stakeholders were on this work session. But I guess at some point we would like to talk to both of them and see what everybody else feels as far as where the hospitals are, where the advocates are, just to hear from their end. So I don't know if we will have another time, or can we do this in full committee?
Well,
I don't think we have since I've been in
no, we've never done it in my time here.
Right.
Delegate Kelly, did you have a comment or just you hadn't taken your hand down?
Oh, I'm so sorry. I haven't.
It's okay.
I'm so tired.
Let me ask if there is a motion on the bill as amended. And so that we can at least take a vote to the committee, to the full committee.
Move the bill as amended.
Okay.
Second.
Got a motion and a second. We have discussed it fairly thoroughly. Is there anyone who wants to discuss it?
I'm just gonna say that I'm gonna abstain from this vote just because I really want to talk to the hospitals about it. I want to read through the bill in a quiet place where there isn't all this, moving and stuff. And just so that I know whether or not I want to put my support behind it. I totally support the intent as long as we do it in a very thoughtful, responsible way.
Then Delegate Sample Hughes.
Thank you, Madam Chair. I was just going to say, I think we have come a long ways, but I think we might just need a moment to regroup and look at this.
Yeah.
And if we can take until tomorrow afternoon, and you'll still be able to move it through to crossover.
I thank you, Delegate, because that's where my head was going. So we'll find a time for the subcommittee to come back together. In the meantime, we will check in with the advocates and MHA. We will, but please understand that as far as we know, there are the date and the inclusion of the cap are the two outstanding issues. I'd ask you not, if we got consensus on the rest of it, that those are the things we focus on. Okay? Does that make sense with folks?
Yes.
Yes.
Then thank you all very, very much for your time on this. I can't thank you enough. Well, I'll work with Aaron to find us a time to meet again, and after you've had a chance to really digest everything. Okay? And with that, we'll conclude the meeting for today. Thank you all and have a good evening.
Yeah.